Welcome to Amplify Family Medicine, the official podcast by the Alabama Academy of Family Physicians. In each episode, we dive into the challenges, triumphs, and innovative practices that shape family medicine across our state. Whether you are a medical professional, a student with an interest in family medicine, or simply a health-conscious listener, Amplify Family Medicine promises to provide invaluable insights and inspire action. Let's amplify the impact of family physicians in Alabama together.
Hey friends, welcome back to today's podcast. I'm so excited to be joined by Dr. Jonathan Parker. It's great to have you here today. I'm having flashbacks to being a medical student and you being the resident on this.
Yeah.
It's been a long time, but so fun to sit here with you today. You're practicing out in Muscle Shoals now, is that right?
That is right.
Tell us a little bit about your practice.
I have a unique practice. I'm family medicine trained, as you mentioned. I was a resident when you were in med school, and that was been about 63 years ago, I think. So,
like that.
So it's been a while. And so after I did family medicine, my last year of residency, I really felt like I wanted to do obesity medicine. And at the time, there was two obesity medicine fellowships. Didn't exist. We now have about 27 obesity medicine fellowships. So I had to travel around to people's clinics and piecemeal and beg people to let me hang out for a while. And so I got boarded in obesity medicine in 2014 and really have done full-time obesity medicine for the past basically 10 years. And so I have a very unique practice, and so I'm kind of the only real obesity practice in my neck of the woods and kind of out from everywhere else. My practice is essentially about 70% obesity medicine, most of that being referrals from outside people, and about 30% family medicine. But obesity medicine is good family medicine, and good family medicine is obesity medicine, which I I like to certainly say you can't separate those two at all. It's a busy practice. We're a private practice, insurance based. So unlike a lot of kind of weight loss world where there tends to be a lot of cash pay, we're insurance based practice. And it's wonderful. Yeah.
Awesome. Good. Well, so great to have you. And you're certainly uniquely qualified to be here for this topic that we're going to talk about today, because I want to talk about obesity and the obesity epidemic. We'll call it an epidemic that we have here in Alabama. And, I love how you said obesity is a family medicine issue. Family medicine is obesity. It's something that so many of us see every day in our practices. And so great to have you here. I've got a list of questions that I want to ask you, but, we'll go super casual and just kind of chat through them. You good with that?
Absolutely. Let's go.
All right. Let's do it, Dr. Parker. Can you give us just an overview of kind of where you see obesity in the state, where we are, what trends you're seeing, and what we as family docs need to be thinking about in our practice related to obesity?
Well, it's not good. And unfortunately, and we really haven't made a ton of progress in the last really many years. I'll say kind of right out that, nationally, I'm on the board of directors for American Board of Obesity and Medicine, and I'm the only family doc on that entire board. And so there has been a push for absolutely family medicine is uniquely really placed in a place that we really should be the people, really should be the people treating this. And in Alabama, I don't think that any of our listeners are going to, really not understand how difficult and what a big issue it is. I don't think anybody's going to be surprised. I mean, we're about 72% of our population has overweight or obesity. About 36% of that is obesity, and we're really not turning that corner. Unfortunately, we're just not really doing a lot to kind of deal with that, and that's multifactorial in our area. But a big piece of that is, at a state level, we just haven't done a really good job at addressing it. We actually have. I'm on a task force in Montgomery. We have a Obesity and Diabetes Task Force that we've had for about 3 years, and we haven't really, really accomplished a lot. Partly because we still have a very old mentality about obesity that this is somehow a character flaw and a willpower issue, as opposed to a very chronic, relapsing, progressive, difficult, complex disease. And our pediatric population is actually also growing and getting worse. And the really, really, I think, hard thing about is our statistics are really, really bad, but it's such a very kind of personal thing because we see this every single day, all the time. And I mean, these are our patients that we, care about. And one thing that I always kind of tend to press, particularly on family medicine physicians, that, obesity is really kind of the core hub of all of the other comorbidities. And we have basically 272 comorbidities that are associated with obesity. And so really, it's easier to find things that are not, associated with obesity. And by treating obesity first, which is even a trend you're seeing in the new American Diabetes Association guidelines, that weight is a co endpoint, and not just glucose control. By treating obesity first, we're also treating, our hypertension and type 2 diabetes and dyslipidemia and metabolic associated steatotic liver disease and all other things that kind of go with that. And so we also have difficulty with food insecurity and food deserts and preventative services and access of care and kind of all the other things that are associated with that, which play into that. So unfortunately, we're not winning.
We're not winning. And I love the point that you made about how we as family docs are right there in the middle of it. And you made the point about our pediatric population as well. And so, it's not just something that we can key into as a, disease that we see in our adults, but we're starting to see kids be obese at a younger and younger age. And so, we, love our pediatrician colleagues, our internal medicine colleagues, and they are seeing, both ends of it, and we are, or either end of it, and we right there seeing both ends. And so I love the point that you made that we as family docs are right in the thick of it so often. You came to a fall forum, maybe it was 2 or 3 years ago, and gave this really awesome talk about medications that are out there. And that talk, I mean, even in just 2 or 3 years, has changed already.
Yeah.
Because we're seeing so much, and it's not just what we're getting from maybe reps who come out, but I mean, it's all over commercials. The Super Bowl ads were full of it. Our patients are seeing it. They're getting it coming in with them. So, medication questions about, whether it's Ozempic or Mounjaro or Wegovy and Zepbound. And now there's a Wegovy peel. So not even talking about injections anymore, but all those things are getting so much attention lately. Tell us kind of big picture your thoughts on these drugs, and even go kind of smaller, bring it down a little bit. Do you see them as the game changers that perhaps people say they are?
Absolutely. There's no doubt about it. I mean, game changers. I mean, really, probably, honestly, we'll say incretin therapy, particularly GLP-1s, but in tirzepatide's case, it being a dual agonist of GLP-1 and GIP. Really, honestly, maybe antibiotics have had a bigger impact, but it's really that big of a game changer. It's really, you're exactly right, talking about how the landscapes change, and thankfully, the whole GLP-1, it's everywhere mentality over the past couple of years. I've said this multiple times, that these are not new drugs, right? So like, these are 20-year-old drugs, right? So these are extremely kind of well-known old drugs. Even semaglutide, which is Wegovy branded for weight and fatty liver and cardiovascular disease, Ozempic branded for diabetes. That's an 18-year-old drug, right? So that molecule is extremely old. And until Kim Kardashian said she was taking it to fit in Marilyn Monroe's dress, and it kind of popped up on the public eye. um, then it became like, oh my goodness, this stuff exists, but they're not new drugs. And because they're not new drugs, we have a ton of data. I mean, just, an absolute ton of data on these medications. And these really aren't um, just anti-obesity medications. And that's really the unbelievable thing is these are cardiorenal metabolic medications. And the data especially over the past kind of several years, instead of getting a lot of like, well, let's just wait until we hear about what bad's going to happen. It's been completely different, completely different. And we've only gotten more and more and more, good things. Particularly, when you're obesity being this, and I'll probably say this too much, and it just, I'd say this a lot, but obesity is a chronic, relapsing, progressive disease, and it's a chronic disease. And so one of the problems that we've kind of had up until GLP-1s really, kind of became the kind of go-to drug in the treatment of obesity has been, we have always thought of obesity as something that's 100% on the patient, right? So it's 100% on the patient, and as long as they're doing X, Y, and Z, they're going to be good. And if they're not doing X, Y, and Z, then they're either failing because they're not doing it, or if they say they're doing X, Y, and Z, they're not really, and we know they're lying and blah blah. They're just, just really. I know that you're sneaking cupcakes when you say that you're eating salad, and that's just completely untrue. The science of obesity is so dramatically changed over the past 15 or 20 years because of that chronicity and because it's an actual biological problem. And previously, it was because we were really failing the patient and blaming the patient the whole time. We were really driven by short-term treatment, right? And you were driven by, eat less, exercise more. Here's your phentermine. You're going to lose some weight, but then finally you're going to buckle down and you're going to get it. And then we stop, phentermine, and patients gain all their weight back, and then they're like, well, what did I do wrong? I can't believe I'm such a failure. Statistically, if you look at most studies, or the two biggest studies that are cited, about 65% of people that have lost weight previously are going to be back to their highest weight within 2 years. And really, it's about 80 to 90% within 5 years. So if that's a character flaw or a willpower problem, like surely 30 or 40% of people could keep it together, right? Think about all the, patients that you have that are, really great at everything, and they're successful at business and home and everything's wonderful and they're just crushing it, but they just couldn't figure out weight. Like that's ridiculous, right? So clearly that biological driver, and because it is such a complicated biological physiologic disease, GLP-1s are a game changer in being able to actually address that physiological piece. And that's something that we generally have only had appetite-based things. And GLP-1s, even though, yes, we think of them as appetite suppressants, that's not really the magic of incretin therapies. Yes, you get significant appetite suppression, but you're also getting direct lipolysis. You're getting improved insulin sensitivity. Now we know that, basically every tissue in your body has a GLP-1 receptor, right? And the reason why, semaglutide's essentially the best fatty liver drug that we've ever had. Yes, we have Rezdiffra, but the data behind Rezdiffra and Wegovy are substantially different. Diabetes prevention, tirzepatide actually prevents diabetes by about 94%. Semaglutide prevents diabetes by about 74%. We have Wegovy being a cardiovascular drug. You get reduction of heart attack and stroke by 20%, which very close to statins. If you want to, weigh that out. Improvement of chronic kidney disease. We have great chronic kidney disease data. CHF data, which has not been published, is also significantly really, especially in quality of life and congestive heart failure is really important. So, it's just, I could, go on and on and on and on and on. about just the real game changer in what these medications, are doing.
Well, I'm going to go off script because you bring up such a great point about how many, how beneficial these medicines can be. And you're an insurance-based practice. I'm an insurance-based practice. Most
Mm.
of the docs listening to this are. How do we balance that then? How do we balance that when we know that we can prevent disease in our patients and prevent true disease? Like, yes, we'll get some weight loss with it too, and that is fantastic. But I mean, you talk about, fatty liver, we talk about cardiovascular health, all those things, and we're looking at a patient in front of us. We know that this medicine can make a difference and we don't have coverage for it. How do you balance that? And I'm not asking you for the answer. And if you figured it out, then, go make money off of that. But how do you balance that in your practice?
I'll tell you, Dr. Anderson, that this is actually probably, and I have said this in Montgomery multiple times in our meetings, that, when I graduated medical school and residency, if you were not guideline based and you weren't EBM based, I mean, when there were papers published about how you should lose your license, right? Yeah, I mean, you should, you were an absolute dinosaur and you're a dangerous and a menace if you're not doing that. And every single day, right, we have very clear national guidelines on what you should be doing in diabetes, what you should be doing in obesity. And yes, every day you're going to have a patient with absolutely this medication should be indicated and absolutely has every single reason to be used. And yet we're forced to actually not follow guideline-based care and not follow, I certainly didn't expect that when I was coming out of med school or residency that, I would definitely feel like I know what to do medically, and this is not a medical problem. I thought that everything, I'm sure you thought the same thing, right? That our real problems were going to be thinking about what to do and,
Exactly.
and what to do with patient care. And, and let me figure out the medicine part of that. And now really the difficulty is, well, how do I get this, treatment to the patient? It's, we're losing that battle significantly. I mean, that's been part of the task force in Montgomery. What we've been doing for 3 years is kind of arguing this. There's multiple kind of things about this. Thankfully, I'll give some good news first. Thankfully, things are getting better. You're right. So things are getting better. Cash pricing has dropped significantly. We have Lilly Direct, which is having cash pay for vials. We now do have oral Wegovy, which is $140 a month. So we finally have some reasonable oral medication. Saxenda went generic last year, so we do have generic liraglutide, but still fairly too expensive. And the amount and supply has actually been a little bit crummy too. So we've had some wins from a pricing standpoint, but overall, there's a big problem of the patient population is so significantly large, right? So if you're talking to insurers, now let me say right off the bat that while I understand from an insurance perspective that there's cost balances and return on investment and everything else, it is an absolute shame that we're carving an entire patient population out to just not treat, right? If I think about a patient of mine who has, actually, I saw a patient today with a BMI of 73. So patient BMI of 73, significant comorbidities, A1C 6.3, right? So great. We now does not have obesity coverage. So the way most insurances work is insurance is going to opt into having obesity coverage, or they're not going to opt in to have obesity coverage. We're getting a little bit better about the comorbidities. So, surely people know this, I don't know, but we know Zepbound's indicated for sleep apnea. So if you have moderate sleep apnea and you have a BMI of 30, not 27 like most obesity guidelines, then we have another indication. And so you do have some insurances that will cover Zepbound just for sleep apnea. Medicare and Medicaid is a good example of that. So Medicare and Medicaid will cover Zepbound for sleep apnea. Medicaid and Medicare will cover Wegovy for MASH. With a fibrosis, you have to have a fibro scanner, you have to have a FibroSure, your fibrosis level has to be F2 to F3. But for Medicare and Medicaid, you can absolutely get Wegovy for that. You can also get coverage for Medicare and Medicaid for Wegovy for anybody who's had previous TIA, previous stroke, known peripheral arterial disease, and previous heart attack. So if any of those patients are out there and their BMI is 27 or above, then absolutely you have indications for Wegovy. And Medicare picking that up, which also legally made Medicaid pick that up, has really been a game changer in terms of having access to certain people. Now, if they don't fall into those categories and they just have obesity, but no previous stroke, no previous heart attack, they have fatty liver, but they don't have MASH and enough fibrosis to count, it's like, great. You're still stuck there. So it's the most frustrating part of my entire day is that it does feel like my day is more trying to figure that out versus just treating the patient. Ultimately, as pricing drops, insurance pricing has to drop. And previously, we've had an issue where even though cash pricing has been dropping, the insurance list price has actually still been high, right? So it's been kind of silly that you could go in and pay $299 for Wegovy cash, but if I ran it through your insurance, it's $1,200. So what that does is by keeping that list pricing at $1,200, when HR departments and insurances and everybody else is going through this, they're going to say, well, $1,200 a month per patient forever, and 70% of our population is going to meet criteria, we're going to go bankrupt. Now, number one, we know adherence is not going to be 100%, though you have, 70% of people may meet criteria. They're certainly not going to use it. Number two, they're ignoring all the return investment that you get, from treating those patients, of course, and also just, again, the insanity of carving out an entire patient population. If somebody had lupus, we're not like, well, you know what, we don't cover lupus. We don't do that. Because again, the idea behind that is this is the patient's fault, whereas if someone has lupus, they couldn't really do anything about that. So they deserve to be treated, but because obesity is really just, on that person, and I can't express how really, really stupid that idea is, then we can get away and they just need to eat less and exercise more. So that probably answered none of your question except for me just ranting.
So I'm so impressed how you rattled all that off. So docs, if you were listening to this and driving, you're gonna have to come back to this, like rewind. He just gave us such like a great list of people who can get covered. So I'm waiting for this to air so I can go back and know which of my patients can be covered for. So all those things that you were mentioning, but you're right. It is frustrating to no end when we don't want our patients to have diabetes, but when that A1C comes back at 6.3 or 6.4, it's a gut shot. It's a gut shot because you know that patient has no chance of getting this covered.
Yeah, boy, the first time I remember like 2 or 3 years ago, when access really, really, really crunched down and dried up, and even now, there will be certain insurances that, say someone's BMI is 45 and their A1C is 6.7, they're a controlled diabetic, so they're not going to cover a GLP-1. Instead, they should be on, a sulfonylurea, which is not anywhere in any guideline, currently. And I remember the holding this in my mind, this tension in my mind of having to break the news to somebody that, well, you have diabetes, your A1C 6.7. And I remember her face going, oh, thank goodness. And I thought, man, this is, I'm in a bizarro world, like this is a bizarro world, to live that way. And, I'm hoping that, this is the year of change. and that it will be extremely hard to ignore the complete the unethical nature, honestly, of not treating patients and forcing us to not do what we know is what's best for the patient.
Absolutely. All right, so I'm gonna make just a little bit of a shift here because I completely buy in 100% to what you said a couple times about the chronic nature of obesity and how we should all consider it as such. But I know that you see, because I see it too, sometimes the patients who want to rely solely on the medicines. How do you broach that conversation with patients that absolutely we understand the benefits of medications and medications are there and can help, but how do you kind of walk that line of, but we also have to do the things, knowing that sometimes in some patients doing the things, the eating right, the exercise, we can't let that be our crutch, right? But we still want to make sure patients know that that's important. How do you layer that in with your discussion with patients?
I mean, I'll preface this by saying that I do generally harp on using medications in patients because of the real medical disease that's happening. And by far and away, most patients have been inundated with eat less, exercise more, it's your fault, and they've done that. So there are a large amount of patients that have been dieting and exercising their entire life, and I see patients all day long who have given significant effort to doing that. And the freeing thing to them is this is not your fault. It's a medical problem and you need to treat it as such. And so from a medication standpoint, and I promise you, Dr. Anderson, I will answer your question, that from a medical perspective, if you look at the patient population that actually meets criteria for treatment of obesity, we were at 2% 5 years ago. So 2% of people who met criteria were actually being treated for obesity. And I know that it seems like everyone is on a GLP-1. I mean, it's like, oh, there's, it's just everywhere. You can't, I mean, I peeked my head out of the office and a needle just jabbed me in the neck, I mean, like you just can't escape it. Actually, the CDC data this year is 5%. So we've actually went from 2 to 5% of the patient population. So we're still significantly undertreated. There is still a significant bias for physicians to not buy into the chronic relapsing nature of weight and still play this, blame game. So I am absolutely a treat, making sure that we're using pharmacotherapy and using pharmacotherapy appropriately, which also means long-term treatment, right? So I say all that to say that, but a lot of times, because I do harp on that with patients, and that's very freeing, and it's very, patients, we're going to weep and cry because that's the first time, if family physicians would do more of that, to really free their patients that it's not their fault, it's a medical problem, we're going to treat it as such, it would be a really wonderful experience. However, because I just gave you that big long caveat before I did it, a lot of times patients hear, I'm just going to take medication and and so sometimes I'll be 6-7 months down the road, people have lost a lot of weight, particularly if they're on incretins, if they're on GLP or GIP medications, because they're so successful. I have often joked with my dietitian a lot that, like, your job is not very hard anymore, because these are really powerful, really powerful medications, but sometimes I'll be 6-7 months down the road with a patient and they've lost 50 pounds. And, I'm talking to them and going through this stuff and realize none of their habits have changed. They're still, have not had any real dietary change. They have not had any really movement. Their lifestyle has certainly not changed at all. And that is the difficulty with powerful medications, And obesity has to be done, obesity care and obesity treatment has to be done in a very complex, cohesive way. So exercise, movement, changing how we're eating and nutrition. That also includes other lifestyle things like sleep and habits and stress. Those things are absolutely necessary, but they're not sufficient, right? So like that, that's a, unfortunately, when you live in my world all day long, I just think that's a given, right? Like, oh, well, that's just, yes, we know that part, right? We know that needs to happen. But it does kind of cause a problem with having really powerful medications.
Mhm.
How I typically address it with patients is in a few ways. So, number one, just because you're losing weight, and yes, you're going to get healthier, um, there are a whole host of things that aren't going to be accomplished if you haven't changed the other stuff, right? Because you're really not fixing their overall health if their sleep is still terrible, if they're not moving. On the very first visit, if I'm going to put somebody on a GLP-1, everybody knows patients will immediately talk about Ozempic face. Somebody told me about Manjaro butt the other day. I don't know what that is. I don't want any part of it, I don't think. But people really will mention that, and there's a lot of scuttlebutt on the internet about losing muscle mass on GLP-1s, right?
Mhm.
There's nothing about GLP-1 molecules that intrinsically cause muscle mass loss. It's just because there's such potent weight loss. And this happens with any weight loss. You can have your mouth sewn shut and be lost in a desert. You can have metabolic surgery, and you're going to be at risk for muscle loss. But if patients aren't changing their eating, if their protein intake is not high enough, they're going to lose muscle. So that's going to have to be there. And patients need to know that they don't want to be skin and bones, and patients are fearful of being skin and bones. Somebody's going to say, boy, my Aunt Ruth took Ozempic, and she came in and, she was dragging some skin behind her, or something, and it's like, well, it's probably a little dramatic, but, yeah, it's, patients are fearful of that. And that's the reason why it happens. They haven't changed their eating. Their protein intake is too low, and they're also not moving. How do you prevent muscle loss if somebody's on a GLP-1? You move,
Right.
and particularly having some resistance training. And we have plenty of studies that show if protein intake is high enough and people are having resistance training, you can retain muscle mass as you're losing weight. And I pitch to patients that it's not about weight loss, right? Here's the shocker about obesity treatment: weight loss is just a small piece of that. Weight loss happens; it's part of the care of that comprehensive care. But we want you to be healthy, and weight is a part of that. But we want your A1C down. We want your insulin improved. We want your sleep patterns better. We want your sleep apnea fixed. We want your body composition better, including that lower visceral fat and higher muscle mass, which includes movement, and eating. We want you nutritiously fed, and we want your vitamin levels to be normal. If you eat like trash, and even though you're losing weight, those things aren't going to be happening either. And I always will say this to patients, if you don't develop your habits and you lose access,
Right. Right.
then if that doesn't happen and you've done great and you've lost a ton of weight, but your company decides to take it off their formulary, or something happens and you lose access, if you haven't developed those habits, then your weight is going to more rapidly come back, right? So if that statistics I said earlier, within 5 years, it's 80 to 90%. Within 2 years, it's 65%. And sure, maybe we're just pushing a beach ball under the water and trying to temper the flames. But if your habits are in place, your weight gain will be slower. And if it's not, your weight gain is going to be higher.
Absolutely. This has been such a great discussion. And like I said, as docs are listening to this, I know that I've learned so much and plan to go back and listen to it again because I want to make sure that in my practice with my patients that I'm being compassionate, right? That I'm practicing as good medicine as I can. I remember, and now as I'm talking to you, I know where I got this from, but I've started telling patients that for no other disease, and it was you clearly because I can hear this coming out of your mouth now. So maybe you said it at Fall Forum, but for no other disease, for, if a patient has diabetes, we don't just say, oh, eat better and exercise. Hypertension, we don't say just eat better and exercise. We've got good medicines that are out there to treat them. I'm pretty sure you said that, John Parker. I'm pretty sure you did, and I say it all the time. If not, I'm attributing it to you from now on.
I'll take it if I didn't say it, but no, I do say that quite a bit. You're right. So
Yeah, so let's not be afraid of these medicines, for sure, and let's be more confident in caring for our patients the best we can, and fighting the good fight every day, which sometimes is the fight against insurance companies and other things that perhaps keep us from being able to do the things like you said earlier that we feel like are good medicine, and then just continuing to be advocates for our patients. I love how you mentioned earlier how important it is also to reduce that stigma and to just meet our patients where they are and stop the blame game and those things. So, Dr. Jonathan Parker, it's so great to have you join us here today. I appreciate your time and appreciate all that you're doing up in Muscle Shoals. Thank you for all that you do.
thank you. I really appreciate it.